So we're going to conclude this with the riveting vitamin D talk. You know, everyone's like, pregnancy, yeah. Vitamin D, yes. This is good. So I just want to thank my small group. Vin is my mentor on this, and then Amy and Santa have been wonderful. And then my personal group, Katie Odie and Christine Chan are our mentors, and they've been amazing. Thank you. So today we're going to talk a little bit about how vitamin D works, why patients are deficient, how deficiency might affect clinical outcome, and then a little bit about treatment. So I just have to say that vitamin D is so invigorating, we should call it vitamin A+. Yes, yes. So right now we're going to talk about its metabolism. We're going to get this from the sun and our supplements and our diet, and then it's going to be hydroxylated in the liver, which we learned is a very important endocrine organ. And then it's going to go over to the kidney and be activated to 125 vitamin D, and it can be inactivated through a variety of organs. So our patients with CF are particularly susceptible to deficiency, and there's a variety of reasons for this. They have poor pancreatic exocrine sufficiency, and so they have malabsorption of this vitamin. They have reduced hydroxylation at the level of the liver, and there might be some increased enterohepatic wasting of vitamin D before it can really get through to the liver. There's reduced sunlight exposure. A lot of our patients are pale-skinned and wear a lot of sunblock, and also there's avoidance of the sun because of some photosensitivity in relationship to drugs, reduced vitamin D binding protein, and reduced body fat stores to keep vitamin D within the body. Also, there's some increased catabolism through mechanisms of drugs. So increased glucocorticoid use can catabolize, as well as some commonly used antibiotics. This can ultimately have downstream effects on multiple body organ systems, including our musculoskeletal system, pulmonary system, gastrointestinal system, immune system, as well as the endocrine system, among others. To start, we'll talk about bones, because I think that people think about bone most when they think about vitamin D. So vitamin D deficiency has been known to decrease bone mass accrual, increase PTH, increasing bony turnover, resulting in lower adult bone mass, especially adults more than peds in terms of osteoporosis. Interestingly, we don't see much rickets or osteomalacia in this CF population despite the vitamin D deficiency. But when you have poor bone health and you have vitamin D deficiency and you have cystic fibrosis, this can all combine to contribute to and be correlated with overall poor outcomes. So lower FEV1, lower body mass index, and perhaps increased cystic fibrosis-related diabetes. So when we look at the literature in terms of vitamin D and cystic fibrosis, it's the same as everything else. The populations are low, the research is scarce, there's not a lot of randomized control trials. When we look at kids specifically, we see definitely a tendency towards seeing kids who are vitamin D deficient have overall long-term lower bone mass accrual. Not all the studies show this, but a lot of them do. When we look at the adult population, the question becomes, is sufficiency kind of too late for the bones? So Melissa Putman looked at two cohorts, one from the late 1990s and one from the early 2010s of patients, and although the patients from the early 2010s had more vitamin D sufficiency, less elevation of PTH, and higher FEV1s, they did not actually have improved bone mineral density. And so the question is that because the vitamin D sufficiency came too late? Is that because these patients didn't really have nutritional improvements as compared to the earlier cohorts? Is that because they were exposed to more glucocorticoids? We don't really know the answer to that question. So my bony questions really are, can supplementation reverse changes that already happened? Is there an optimal time to reach sufficiency that's going to enhance the bone health the most? are there other factors that we should be concentrating on more? Vitamin D lends itself to a treatment that we can do for these patients, but maybe we should be concentrating on other factors a little bit more in terms of bone health. And will Trikafta have direct effects on vitamin D sufficiency and on bone health, and which is causing which? The next system that we'll think about is the pulmonary system. So vitamin D sufficiency can have effects on multiple aspects of pulmonary health. Lower vitamin D levels have been associated with increased pulmonary exacerbation, colonization, and decreased pulmonary function. Again, the results are mixed. I've taken out a couple of more recent studies. In 2019, there was a study to treat to above levels of 30 nanograms per milliliter in about 90 patients. And when these patients reached sufficiency, there was decreased pulmonary exacerbations. Vin did a really nice randomized controlled trial where he introduced 250,000 international units of vitamin D within 72 hours of hospitalization with pulmonary exacerbation, hoping to improve long-term outcomes. This was based on a pilot study that showed some promising results. But in this multi-center study, there was actually no difference when this was introduced within 72 hours of time to next pulmonary exacerbation, hospitalization, survival, or lung function. There was a meta-analysis that came out just last year looking at randomization of vitamin D intervention to placebo and then looking at any outcomes. The previous meta-analysis to this had 4 studies, and they have doubled the number of randomized control trials to 8 studies, but of course, paucity of information, and because the outcomes were different, they really couldn't show that vitamin D interventions helped with clinical aspects, although vitamin D intervention did raise vitamin D levels. When we look at the gastrointestinal system and the immunologic system and the endocrine system, I think that the underlying theme of all of these, as well as the pulmonary system, is that the immunologic effects of vitamin D might contribute to multiple organ systems. And so in the gastrointestinal system, we see that there might be a shift towards beneficial gut microbiota and maintenance of integrity of the gut mucosal barrier. And in the immune system, we see that it enhances innate immunity, inhibits adaptive immunity, and reduces inflammation and potentially autoimmunity. So when we extrapolate this to the diabetes literature, when we look at type 1 and vitamin D sufficiency, we see that those patients who reach sufficiency have actually a shift from the Th1 to the Th2 cytokine preponderance, which can help clear autoreactive T cells, decrease cell infiltration into the islet cells, and reduce cytokine-induced beta cell damage, thereby potentially preserving some beta cell mass. Obviously, vitamin D does not treat type 1 diabetes. Type 2 diabetes, the literature shows that sufficiency will increase insulin secretion and improve peripheral insulin sensitivity. So then when we take this over into cystic fibrosis-related diabetes, in our younger patients, studies have correlated cystic fibrosis-related diabetes with increased vitamin D deficiency or insufficiency, and also impaired glucose tolerance the same. So the impaired glucose tolerance goes up as the sufficiency goes down. And we might see a little bit more effect in kids with this because they might have more beta cell mass, preserved insulin secretion, and better insulin sensitivity. In contrast, in adult studies, although small, vitamin D sufficiency did not correlate with insulin secretion, glucose metabolism, and resistance indices. So in this particular study, the population just happened to be more vitamin D sufficient than in general, and so that might have minimized the effect a little bit. And the patient population was older, so going back to the basics, there just might have been less to do for that population. So now we're going to talk about treatment. So when vitamin D supplementation knocks on my door, I invite them in. You know, bring it. Okay, there you go. It's vitamin D, you guys. I stayed up for like an hour finding these puns for you. Yeah. So I just quickly put in a couple of slides from the Cystic Fibrosis Foundation in terms of their recommendations. They do recommend to treat to vitamin D levels of 30 nanograms per milliliter or higher, primarily utilizing vitamin D3 because it's been shown in several studies to be more effective than the formulation of vitamin D2, although vitamin D2 at kind of double doses has been just as effective. You want to monitor your once yearly levels and 3 months after changes, and be mindful of not getting toxic on vitamin D. So some of you might be aware that Europe actually recommends levels of 20 nanograms per milliliter rather than our 30. But this study very nicely shows why 30 might be actually a better target. So what this study did is it took iliac bone crest biopsies from 675 cadavers and concurrently tested vitamin D levels, which you might wonder if taking vitamin D levels from a dead person is accurate, and apparently it is. So they tested their vitamin D levels. They were largely insufficient. So you can see this is the level of sufficiency that they had. This is nanomoles per liter, so 75 is equivalent to 30 nanograms per milliliter on our scale. They were largely insufficient. And then what they did is they looked to see where there was pathologic osteoid formation per bone volume. And there's a couple of different markers or levels beyond which we think it's pathologic. So the conservative measure is 2% development, but many people use 1.2% or above being a pathologic osteoid development, and this is bad bones, okay? But you can see that above the level of 30, nobody had pathologic formation there. Their osteoid surface also, nobody had pathologic development, and the thickness, nobody had pathologic development. So it may be that above 30 is a better marker just because it gives you that level of comfort that probably they're not having pathologic negative bony changes above that level, and it gives you a little bit of cushion. So if you're gonna get your vitamin D, you want it from your diet, usually vitamin D3 or from the sun. And the formulation for cystic fibrosis patients might play into account. There's no formal recommendations right now, but because there's fat malabsorption, a powder-based vehicle might be a better way to go. There's stage dosing according to age and severity of insufficiency. And again, we don't know if weekly dosing or once daily dosing is better, but we tailor it to the patient's compliance. So in summary, give lots of vitamin D. Give it early, achieve sufficiency, and as always, we need rigorous randomized control trials. This is my family.